meeting and forum that we have today on Blindness Prevention Week by the IHW Council. The Council is looking at various ways of making interventions, getting stakeholders together, making policy propositions, and also looking at solutions to the vexing problems, the health crisis, the health issues, and health subjects of India and of the world. And today is no different. As we celebrate Blindness Prevention Week 2023, we are having a panel discussion, a power-packed panel discussion, and featuring some of the leading names and luminaries in the field of ophthalmology as we look at ending blindness by 2030, integrating eye care management in health systems. And this subject is particularly important when we are looking at scale, when we're looking at size, and when we're looking at impact. And India has had a rich history and tradition of having national programs, interventions, the use of a wide stakeholder community approach in ensuring that the burden from blindness is reduced as much as possible. But challenges remain, and those are some of the areas where we will be delving deeper into the issues, into the solutions, and also the learnings that we've had. Blindness, as we know, is a major is not a crisis, but is a major issue when you look at what it does on the personal impact on health and well-being, and also the financial impact that it has. Just some statistics, the WHO predicts that 2.2 billion people have some sort of vision impairment, and the personal impact on that is great. But even on the financial impact, as per the WHO's estimate, $411 billion of productivity loss is what is estimated because of vision impairment and what it does. And to discuss all of these issues, the whys and the hows and the way forward, I am delighted to be joined by this power-packed panel. You couldn't have asked for a better one than what we have today. Dr. Anil Kumar, Additional Director General Ophthalmology, National Program for Control of Blindness, Ministry of Health and Family Welfare, Government of India, is with us here today. Dr. A.K. Grover, Padma Shri, Chairman and President, Department of Ophthalmology, Shri Gangaram Hospital, and Chairman of Vision Eye Centers, Professor Dr. J.S. Tithyal, Padma Shri, Professor and Chief, Dr. Rajendra Prasad, Center for Ophthalmic Sciences, pardon me, AIMS, New Delhi, and Chairman of National Eye Bank, AIMS, Professor Dr. Praveen Vishisht, Professor and Head Community Ophthalmology, Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi, Dr. Patanjali Dev Nair, ophthalmologist and former Regional Director, Disability and Rehabilitation, WHO CRO Region, Dr. Shailendra Sabharwal, Associate Medical Director and HOD Community Ophthalmology, Dr. Shroff's Charity Eye Hospital, and last but not the least, Dr. Gopal Pillai, Clinical Professor and Head, Department of Ophthalmology, Center for Eye Diseases and Marfan Syndrome at Amrita Institute of Medical Sciences, Kochi. My welcome to this entire panel. Thank you for being here today as we discuss this very important subject around blindness and what we can do. And I'll start straight up with Dr. Anil Kumar. So if you could just give us some insights into what has been the government's role, as I touched upon in my opening remarks, on prevention of blindness, and why is it such a big issue that the government has this vast program to control blindness in the first place?
So, as you know, we have the national program. Within the national program, we have a system where we have the state level authorities, district level authorities, and they support the program. We have the program guidelines, and we implement guidelines through the system, and then, of course, the National Health Mission. And the Directorate General of Health Services, the program manager here, he oversees the program being implemented effectively in the country. And we monitor the program. We get the data on a regular basis from all the states. And our team, we have regular meetings with the state program officers. So this is what we are able to do. And I will not go into the details known what do we have in the program. But what we plan to do in future to achieve the target is to integrate the program at primary healthcare level. I think at that level, integration is required. When our ASHA is there in the village, which is one major strength in the national healthcare public healthcare delivery system. So we have to involve the ASHA more so that she is able to detect visual impairment for the population, the population of 1,000 for which she is responsible. So we have to energize ASHA so that she is able to refer the case to primary health center. And primary health center, again we have to further, we have to do capacity building of the medical officers present at primary health center. So that part, we need to further strengthen. And awareness level. So awareness level, we have to further increase the awareness level, for which we are planning to have the activity in which we involve even the panchayat members present at the village level. And also, the surveillance system, which is very, very important. We have to further strengthen the surveillance system, because presently we are dependent on the periodic survey which we have to find out, to know what is the level of visual impairment in the country, or the blindness. Once we have a good surveillance system in place, we will be knowing which particular district is lagging behind in their program implementation, and which particular district is doing good work. And then we can, we can have the targeted intervention to take action, whichever district is lagging behind. So this is in nutshell what we are planning to achieve what we want to achieve. Thank you.
Right. So it's a wide-ranging program. It is going down right to the primary health center level, using ASHA workers, surveillance mechanism, and then planning interventions, and doing this across the length and breadth of the country. So it's no mean task. And congratulations to the ministry and to the program specifically for the impact that it has had. We've seen a trajectory which is actually showing the prevalence going down of blindness, but we know that challenges remain. But nonetheless, I think it's commendable what India has been able to do around that. Dr. Grover, if I could just bring you in here, and we heard Dr. Anil Kumar speak about the impact the program has had, and what it has been able to do over the past 4+ decades. But if we come down to the moot question around the prevalence of blindness, what was it? What is it? Why is it such a issue of sort of crisis proportions?
Now, we've had traditionally the highest number of blind in the world have always been reported to be from India, and it is a massive problem, as we know. The country has had a very good tradition of taking care of them, and I think we were first of the block to create a national trachoma control program, going on to the national program for control of blindness, which has been effective. And as the recent survey which All India Institute did with Dr. Praveen Vashisht has shown, that we've been able to bring down the prevalence to the level of 0.3, which is what we had aimed for some years ago. And that in itself is a major achievement. But the fact remains that our concentration has been on secondary care, because traditionally the cataract has been the major issue, which has been always considered and has been the most important cause, and that has been dealt on a crisis basis, first as as outstation camps, then the in-hospital camps. But increasingly, we realize that we need to expand out to carry forward to universal eye care. And that requires integration with the primary health care to bring about a universal eye care. That is one aspect of it. And second is that we realize that there are a number of challenges which were not addressed so well during the phase when we were concentrating primarily on cataracts, such as the corneal blindness, childhood blindness, the refractive errors, and the glaucomas, and the diabetic retinopathies, which are a major cause for blindness. and those were relatively unaddressed. This has recently been focused upon by the National Program for Control of Blindness, and concentration on these has improved. Infrastructure has improved. But as we all know, the challenges remain, which is, of course, a lot to do with the equity, that we are not able to provide the same level of care in the for those who are economically not so well to do, and in the rural areas we've not been able to provide the care to the same level. So those challenges of equity, quality is another area where we can do a lot more about, and the manpower, the infrastructure. These have been the main challenges which have hampered our activities. I think we need to increasingly focus on this and to expand towards primary eye care, which can only be as a part of the primary health care. So these are the areas to look forward to in the coming years so that we get closer to our goal of universal eye care by 2030.
Right. And Dr. Gopi, you touched upon some of the causes. Has there been a change because of, there's a changing landscape of the prevalence of diabetes and other diseases? So have you seen a change in the causation to vision impairment as well over the past 4 decades?
Huge change. When we started off our professional career in ophthalmology almost 4.5 decades ago, there was virtually very little age-related macular degeneration, very little of diabetic retinopathy as a cause of blindness. And glaucoma was much, much lesser. We were talking at those times when I was serving in glaucoma service at the All India Institute, about angle closure glaucoma being almost the same as open angle glaucoma. But now we know that open angle glaucoma has become so common that open angle glaucoma or normal tension glaucoma outnumbers angle closure glaucoma by almost 10 to 20 folds. And that is only because of increase in this rather than any decrease in angle closure. So, which shows that those changes which manifest with age or with increasing uptake of services by the population, those have become much better, much more important from the public health viewpoint. And we need to be addressing them with much greater emphasis. Glaucoma, certainly. Diabetic retinopathy, certainly. Retinopathy of prematurity was another area which has been addressed reasonably well with much greater awareness, much greater effort at picking them up early. But there are a number of areas which need even more emphasis.
Right. And I'd like to bring in Professor Tityal at this stage. We've heard, about the national program, the impact that it has had, but it still remains a public health issue of concern. There are areas around equity, access to trained manpower, quality of services themselves, entire gamut of issues. And you have a nice perch point, Professor Tityal. The center at AIMS is considered as a center of excellence, which is also part of national programs. How do you see the past 4 decades, and what are the insights that you can share for how do you think 2030, the targets that we set out for ourselves, can be achieved?
Good evening, all of you. It's very, very, heartening that we are sitting together and discussing a very important aspect of blindness and visual impairment. And Dr. Anil and Dr. Ashok has nicely given a brief what we have achieved in the last 5 decades in our country in terms of blindness control program wise, and there has been a success in that story also. But with the increasing lifespan of people, increasing newer diseases affecting the eyes or a vision, the proportion of people suffering from blindness or a visual impairment has increased, and that is going to increase further also. And what I see, like what we have achieved is, one aspect, but the future challenges are much, much bigger. I don't think by 2030 to achieve something will be a very, very great achievement now. I can consider, and has to be a targeted approach from all sectors to achieve something of that magnitude to decrease the prevalence of these blinding disorder, which has increased in number, as Dr. Ashok Grover nicely highlighted. The number of people suffering from a diabetic retinopathy causing blindness. Glaucoma is a hidden subject. It's a hidden disease to cause a blindness. Similarly, it's a hidden subject. We don't know how many people are suffering from glaucoma. The diagnosis is difficult in the community, and doing survey for these patients is also very difficult to pick up. So that's the real challenge for future. Similarly, at this juncture, apart from the cataract, we still have a huge number of cataract patients to be treated by us. The refractive error is a major challenge which is going to be there for the next 2-3 decades, especially in all age groups. Younger age group, myopia is getting epidemic proportion. Similarly, presbyopia is a major challenge for us for the future, because larger segment of people are going through this age group where they require glasses for near to bring up their routine work or to complement their work style, which is the challenge for future. And giving the presbyopic glasses to these people are going to be a major challenge for all of us. And Dr. Parveen Basis will highlight what are our target, what we are going to do in future for these people. And that's a huge challenge, and challenge is going to compound because every 2 to 3 years, the power requirement for near changes. If you give a glass today, after 2-3 years, we may have to supplement another pair of glasses, those people. So that is one. But what I foresee, I think this is the time we should discuss not only the treating the blindness for these people, we should think of a preventive aspect of these blindness areas. So that will only depend on how do we survey the entire country in terms of the magnitude of these disorders causing impairment of vision and blindness. And Dr. Ashok nicely highlighted the infrastructure, because we do survey, but if we don't have an infrastructure, which has to be manned by the manpower of all categories up to the specialized category also, so that we actually give the treatment for these people at doorstep. And in terms of prevention, these lifestyle change will be difficult for us. Diabetes will be there. But other thing which I always talk about is, preventing injuries, which is very common in India, in the pediatric age group as well in the working age group. The dryness is a major challenge for future, which ultimately going to cause huge impairment for these people. And so many people are blind, which require assistance. That area we are also working on to look for assistive technology for people who are suffering from visual impairment, so that they get to a lifestyle where they can do something for themselves and support their family and the country as such, the community. So assistive technology like low vision aids has to be another challenge for us. So I can see we have a target, but we have a huge magnitude of problem in terms of blindness, visual impairment, their causes, the surveys, screening of these people, building infrastructure, then supplementing that infrastructure by the manpower is going to be a challenge.
Right. And Professor Titial, if I could ask, diabetes, which has emerged as a challenge, is also because of social progress. In many ways, it could have other reasons as well. But as we improve on our social and health indicators, and also improve our determinants around food, water, access to nutrition, has the picture improved in terms of vision impairment?
In terms of diabetes, it's not that we are thinking now only it has been there. The only problem is the type of a diabetic retinopathy, the disease which is going to affect the retina. It's not that every patient is going to go blind. Therefore, the early detection and management is important. The surveys which we have done will show around 4 to 7% people have a blinding disorder. So even that number is a huge. But now awareness has to be there, not only amongst the ophthalmologists, awareness to the patients and awareness to people who are treating diabetes. That is our medical team, like people who are internal medicine people or people who are looking after the diabetic profile of patient. They have also be educated enough to send these patients for a screening of their retina, so that we can pick up their early disorder and prevent them to that stage of blindness, which can cause diabetic retinopathy blindness. But the good thing is now a lot of programs are going across the country. The ophthalmic societies are working on these areas for creating a tele-ophthalmology system where people can be screened, and those retina can be seen by the experts sitting in metro cities, and give them ways to handle those patients. So this future of teleophthalmology also is very important aspect to cater to these primary healthcare areas to a central area, so that people sitting in a central area can also give a judgment in terms of a type of disease disorder they are suffering, and give them a guidance where exactly those can be treated. And this network has to be supported by the central government, NPCB, Ministry of Health, so that we have a network which covers the entire country.
Right. Just before I go to Dr. Patanjali, I just like to ask Dr. Anil Kumar about that. Sir, Professor Tityal spoke about teleophthalmology, and we know technology will have a huge role to play now and in the future. Could you just throw some light on how we're using technology for our various national programs around vision impairment?
So presently, we are working in that direction. Various programs through which we have started activities like consultation through our system, through using information technology, that is already there. But as far as telemedicine is concerned, we have to move in that direction. Our policy is that to use telemedicine as far as possible. That is we are very clear about it. But we need to probably work in that direction. And also for telemedicine, we have to develop, the enabling environment at primary healthcare level, at village level. And we have to, involve various, various government agencies, like, Panchayat Raj system. So that we are definitely moving in that direction, and we are positive about it. And we are definitely going to, to the telemedicine for this purpose.
Right. That's very heartening to know. Dr. Patanjali, I'd like to bring you in and turn our gaze internationally, or at least regionally. You have a lot of experience in that, both as an ophthalmologist and also for someone who's worked very closely looking at this problem from the WHO's side. But specifically for the WHO, they have suggested two global indicators. They talk about cataract and uncorrected refractive errors. What was the rationale behind that, and where have we gone with them so far?
Thank you so much for this pointed question. And I'd like to remind our august listeners and, of course, the panel that my previous speakers on the panel have actually touched upon the area quite well. That is the numbers. So, Dr. Karan, numbers are huge. 100 million people are blind because of cataract vision globally, and 800 million are having, partial or vision compromise because of many factors, largely because of uncorrected refractive error. So that's one. So that's one area which has come up. In dollarization terms, we know the loss being caused in, how many billions of dollars. Those are estimates. But what we know is that preponderance of both these is in the so-called low middle income countries. And ours is still comes in one of those countries area. So we are unnecessarily, I would say, use the word. And as Dr. Tityal has pointed out, Dr. Nanlil has very beautifully pointed about the integration, what government is doing. And of course, we have heard Dr. Ashok Grover, who's a huge practice and experience in many areas, brings those out. But why are indicators made? One of the questions comes up. These two targets arose from the resolution 73.4, which the World Health Assembly passed on integrating eye service. That's where I was linking it up with what Dr. Anil brought up, that for integration, they said, okay, how to integrate. In fact, we have had a very good paper on how to integrate, and we can maybe have another discussion with IHW on these areas and how, why, where to integrate, etc. But the global targets arose because it was found that these two need to be tackled first. That you cannot have in the modern world people living with cataract. And there are no reasons for that, unless if you what are the reasons you find are programmatic? They are usually with the governance. They're not technical. The ophthalmology, as Dr. Tityal spoke about, has evolved so much that we can use technology. And it gladdened my heart to listen to him talking about many of the works which we have supported from WHO to AIMS, by the way, which is our WHO collaborating center. The topmost center. We have 4 or 5, but there's nothing beating the RP center. And Dr. TTL and Dr. Praveen Vishwas in this team have carried that out. So the two global targets given that, cataract surgical rate, effective one, to increase by 30 percentage points. And if any country has around 70%, then they should go for universal coverage. That's what 30%. So it's a pretty comprehensive target. And I do agree with Dr. TTL that is a challenge for a country like us. But unless you pose challenges, Dr. Karan, the programs don't gear up. It's work as usual. So one of the purposes for having global target is see that you channelize the programmatic forces into, it's like laser beam, into focused areas and do that. Of course, as Dr. TTL brought about that for the refractive error coverage rate, which is 40%. So that means any country which is around 60% is asked to reach universal coverage for them. And for India, it is a challenge, no doubt about it. But then we are here to meet challenges. You see what has happened, Dr. Karan, and as all my other panelists, the passionate ones agree, just because there's a challenge, it would not mean that we would sit back and say, oh, it's too difficult to do. The whole purpose is to get it done, knowing well there are challenges, but all of us have to collectively put our heads together and find out the ways and means to meet the challenges. Not be thwarted by them and sit at home and say, no, it will only happen 3%, 4%, 5% a year. That's one of the points to come out. Interestingly, just 2 months ago, we had a meeting in Hyderabad, and this is an addition one here. Dr. Praveen Vishwas was one of the main facilitators, where the region adopted 2 more targets, and there, one is for diabetic retinopathy, that 80% of them should be seen by a retina specialist or an ophthalmologist and 80% of those who need management treatment, as Dr. TTL and Dr. Ashok Grover brought out, should be able to find that out. So India and the countries have gone much beyond even the global targets and added this target, plus the 4th one is on trachoma elimination. They come up. And I think glaucoma would be taken up by the next meeting or so once we manage that, as all the 3 previous speakers have brought about. So I'd like to reiterate 3 points here. Targets are necessary, they're needed. They propel the programs to move in a particular focused direction. And third, India and the region has gone beyond the global targets and added 2 more targets to that. And we hope that we will all collectively be able to make severe dent on these areas. Thank you.
Right. Thanks for that exposition of why we need these targets and how they help in integrating the system. Dr. Patanjali, I also want to ask you about some bright spots. You would have seen health systems, national programs across not just the Southeast Asian region, but across the world. What are some 1 or 2 highlights that you could share, which would be useful for the Indian experience going forward, and especially with this target of 2030?
Very interesting question. And, and yes, you're right. I was posted in WHO Manila office also, Dr. Karan. And of course, Praveen ji knows about it as there. So that is a region which is in 37 countries of the Western Pacific region, including China, Mongolia, Malaysia, all the Pacific islands. Then I was posted in Maldives. That's through the WHO. Interestingly, I'm very happy to inform you that the India and Sierra region are much ahead of most of the low and middle income countries. Now our competition and our sights are on what the high income countries have achieved. And I think India, being an aspiration one from the last few years, as in all areas, is also in health field, especially in ophthalmology. We are the topmost people. We are the topmost programs. We are the topmost institutions. What these countries can afford, forget about, and people come from all over. 2 examples I would raise, and especially Dr. TTL has pointed out, is one is some of the countries, especially Latin American countries, have been working for uncorrected refractive errors and offering spectacles to the people in need, especially children. The numbers go in millions. There have been NGOs who have done that for the areas. In cataract, other ways, we need to find out some of the innovations, but since that surgical one is required, refractive error correction can get stakeholders together. And I remember that we had a meeting in Dr. TTL had opened, I think 4 months ago at the RP Center. I think it was the boardroom of the AIMS. where this topic was discussed. And I was quite categorical because there was question that we should be going to the public figures like PM, CM, DM, etc. And I was of the opinion that this rests squarely with us. This is an area where we all stakeholders, it is up to us to bring that about. So that's one segment. Secondly, from the region coming up, we did it in Bhutan. The LB Prasad Institute brought us here, and we brought up Essilor and a couple of other companies to distribute spectacle to each and every student of Bhutan who needed it. So around 2 lakh spectacles were given. But that again, I marvel at what TTL brought about here. There has been no follow-up. Nobody is there now to give the next supplement, even to children. After glasses break also. It's not only for the press biopsy that they need a correction, but also children require, and they are quick and they are active. So Dr. Karan, when we come to the issues, these are some of the related issues, but that is where I'm so happy that they have come up, and Dr. TTL, Dr. Anil, and Dr. Ashok Grover already brought them out, is we need to put our heads. It's neither easy, but it's neither so difficult that it cannot be done. Okay, if we can't do 40%, we should at least be able to do 30, 35% of it or 40% of it. Whereas I would still push our countries by 2030. You never know, 7 years is good enough time that we're able to do it. So I'll stop here by saying that the examples are there, but in the last, my caution would be we will have to develop our own models. You know, it's good to learn from the other countries, other regions of the world, but many of them will not be able to supplant as that was done there, but we'll have to work with them and learn from them, but develop our own models for both the things, or rather say, I would say all 4 of them, for diabetic, for cataract, and for the refractive errors. I'll stop here.
Right. So if we ever need a Make in India program, it has to be for ophthalmology, for India,
and for the region, Dr. Karan.
And for the region, yes.
We are the leaders for the region. I'm very proud to say that. That's all because of the hard work of the people here. Many of them are here, and many who are not. And people from the past, you're riding on the shoulders of the giants. Never forget that we are there. So that's the point I would like to make up. We'll have to find out answers. I think the answers are blowing in the wind.
Right.
Thank you.
I'd like to bring in Dr. Praveen Vishesh. Dr. Vishesh, Dr. Tityal also spoke about, surveys, surveillance, and the impact they have, both in terms of understanding the progress that we are making, the size of the issue, how our interventions actually impacting on the ground. And you've played a large role in those national surveys, or even participating front and center in these various national programs around vision impairment. I'd love to hear your insights on how these surveys are run, what has been your experience in terms of what they are telling us, and how do you see the trajectory going forward to 2030?
Thank you, Karan. In fact, for last 10 years in RP Center, we have been doing these national level surveys, and I'm very thankful to Ministry. They have sponsored most of these surveys that include National Blindness and Visual Impairment Survey that we conducted from 2015 to 19. And as per that survey, we were able to show that, as Dr. Ashok has mentioned, the prevalence of blindness is reduced to 0.36% now, against a target of 0.3%. And we started in 1976 with 1.38%. So there's a significant reduction in blindness. The WHO, they have kept a target for visual impairment. In all countries, they should reduce the prevalence of visual impairment by 25%, and to the baseline as 2010 figure. With the help of this national survey, we were able to show that we have reduced visual impairment by 51% instead of just 25%. It was like in 2010, it was estimated as 5.3%, and we have shown that it is nearly 2.53%. The significant reduction in visual impairment in our country. We also did the major causes of blindness and visual impairment. When major cause of blindness is again cataract. Dr. Grover, Dr. Tityal has mentioned about this thing. Major cause of visual impairment in our country is refractive error. Corneal blindness has emerged as the second important cause of blindness. This is another important. Trachoma, vitamin A deficiency are not at all important cause of blindness at this stage. We did survey in children also, 0 to 49 age group also. We found that it is not cataract, it is the corneal opacity, which is major cause of blindness, responsible for nearly 37% of blindness. We also did national survey on diabetic retinopathy. Now we see in 50 plus population around 11.8% people are diabetics. we have took a criteria was more than 200 milligram per deciliter as diabetes. And among them, 16.9% are diabetic retinopathy. And 3.6% of diabetic retinopathy is actually sight-threatening DL. So these are the findings which are able to get. In fact, as Dr. Tatanli has mentioned, that we have now two major indicators to assess the actually progress related to universal health coverage, that is effective cataract surgical coverage and effective refractive coverage. With this survey, we are able to show that in our country, though we are doing nearly 65 lakh surgeries per year in country, still the effective cataract surgical coverage is around 31% only. And if we have to achieve a universal health coverage, it should go to 100%. So we can't think of achieving it by 2030. We can think of just 30% per point percent increase, around 61% by the year 2030. In fact, one important aspect which I would like to mention is conducting another area of survey, the corneal opacity survey, which we are doing currently with the help of ICMR has sponsored this survey, and this will finish in next 1 year. We're also doing national trachoma survey. Trachoma is one disease which is there probably in India only out of all CRO countries. India is not yet declared. And I believe if we actually have done surveys in way back in 2000, probably we could have declared at that time, because the burden is not much. It is actually the survey that has not been done. So now we are doing, with the help of WHO as our partner, we are doing survey in 200 districts. Survey is part of National Program for Control of Blindness. We have to finish this survey in next 3 months. And after that, we can show globally that trachoma is also eliminated from our country, which is one of the target indicator by 2030, we can achieve by 2023. So these are the various surveys which we are doing. In fact, I wish to do National Refractive Error Survey to actually assess the prevalence of refractive error all over the country and what is the effective refractive recovery. This is our next plan of target, and hopefully we'll get some sponsorship for that.
With your focus, I'm sure this would be made possible. But the surveys would speak to you on also possible solutions. What are the areas that, when you look at the surveys, you look at the progress, you feel that we need to put a lot more focus? You spoke about vitamin deficiency may not be the primary area of focus given what the other causality and factors are. So could you just share some insights on what those areas are, basis the survey and basis the progress?
Or the key reason for blindness or visual impairment at this stage?
Yes, and therefore we should focus more on them.
Yeah, this is very clear. In fact, with the help of, as outcome this survey, we have given the number to Government of India that we need 2.70 crore surgeries in next 3 years for cataract. So cataract is a major emphasis. 66% of blindness in India is due to cataract. In fact, it is also coming as a second leading cause of visual impairment also after refractive error. So cataract is the key. The second important factor, as I mentioned, is the refractive error. We are not even aware what is the coverage of effective coverage of refractive error in our country. Some of the studies done at local level shows around 25%. And we have to increase by 40%, which is not easy task actually. We don't have optometrists in our country. As per the recent survey, human resource survey conducted by RP Center, we just have around 17,000 optometrists, qualified optometrists working at the secondary level hospitals against a target of 78,000. And in terms of ophthalmologists, what we have shown that the number is around 21,000 ophthalmologists against a target of 25,000. So number of ophthalmologists quite near to our targets, but number of paramedical ophthalmic assistant optometrists is a huge lag. So refractive error program, other program which are linked with optometrists or ophthalmic technicians, that is a major. As Dr. Anil has mentioned, our emphasis on primary eye care, but for ophthalmic level primary eye care, not only ASHA worker, you need ophthalmic technicians, optometrists to provide such services. And that is a huge lacuna in our country. That is the area which you need to emphasize.
Right. So, Dr. Grover, I'd just like to bring you in, and you set the stage actually for both what the surveys are telling us and also issues around equity, but resourcing, both hard physical infrastructure and the human resource. And Dr. Praveen has highlighted, why that continues to be a problem. What are some of the ways that we can address that going forward for the next 7, 10, 15 years?
I think the one area that I would particularly like to address is the human resources. Dr. Praveen Vashisht so well pointed out that the ratio that we should have of ophthalmologists to optometrists should probably be 1 to 3 or 1 to 4. so that they are able to not just to assist in the ophthalmic programs and increase the effectivity of the ophthalmologist, but do independent work in vision centers, which could be an important way of primary or universal eye care. So vision centers could be manned by optometrists or people who are at least trained in some way to be able to handle the refractive errors and to be able to use teleophthalmology to communicate the difficulties that are present at the primary healthcare level. So that is one very important aspect. The second is regarding the kind of training that we have. As was pointed out, we have some of the best centers in the world, some who've done great job, not just as training centers for ophthalmologists at the super specialty level and at public health level. They are the ones who have helped us plan the national plan so well, and to be able to spread it across much better than what it was in the initial years of the national program, and plan things in a more systematic manner. But there are still huge gaps in terms of quality of the training that is being provided to ophthalmologists as well. So as I wrote in one of my editorials long ago, the training varies from sublime to ridiculous, because there are many who would pass out without having done any surgical exposure at all. And that is an area which needs to be addressed. And for good training to be present in medical colleges, it is important that we develop subspecialties. And unless the subspecialties are more standardized and developed well, the training in the medical schools or the residency training will not become good. And the motivation levels at the medical colleges need to be increased. The complaints often are of the diversity of the range of work that the postgraduate teachers are required to do other than the specific areas of patient care and teaching. And that is where sometimes the motivation suffers and the training of the residency level is not as good as it should be. So that is one area where our focus should be, and a much greater emphasis on training of para-ophthalmic personnel or the optometrists, maybe by increasing the number of training institutions, which is something that will have to be thought of as a part of National Program for Control of Blindness at the ministry level. And that could be a very important tool helping in the universal eye care.
Right.
As for the infrastructure, I think there has been a lot of emphasis recently under Ayushman Bharat about providing primary care besides the secondary care. But the resources will need to be not just allocated, the equity part of it taking care of at least those who opt to work in the areas which are relatively deprived or the rural areas. They need to get many more incentives. So only then will people move over to those areas to provide infrastructure in the areas where it is needed more.
Right. I'll just come to Dr. Sabharwal and Dr. Pillai, but before that, I just wanted to get Professor Tityal's view also on the various reforms that have taken place. There's been an expansion of the graduate, postgraduate seats, which should in time increase the pipeline of trained human resource being made available. How do you see this both as a challenge and also some solutions to address this human resource issue?
I think beautifully covered by Dr. Ashok Grover regarding the how we have to support the infrastructure by this skilled manpower. As far as training of ophthalmologists are concerned, I think yes, there is some shortcomings, but it can be managed with uniformities coming in the postgraduate teaching programs from NMC, and that also will have a uniformity. As such, I think institutions like ours, there are institutions where they should share the burden of training people from across the country. The program started, I remember World Bank started cataract training program in the past. Ministry of Health, they're doing training of specialists in these areas of subspecialty work call. and that has to be upgraded again, especially now new things coming up. How do we train people to detect diabetic retinopathy, and how do these trainers train their trainees to pick up? So there has to be one program which is we called training to trainers, so that we train our trainers to make them the channels for increasing the manpower to detect these important areas. One thing I always talk about is these paramedical courses, especially the ophthalmic technicians or optometrists. We need to have a council under the Ministry of Health or a NMC, so that they come under one roof. And we have a uniform program for the entire country. Today, we don't have a uniform program for these people who are doing optometry or ophthalmic technicians. It's a real challenge, I can understand, because we have some programs which are only for 1 year, some 3 years, some 4 years. And subsequently, their training module is also not unique or uniform. So we need to have today, I think the council has to be there for these people, like we have for our medical council. The optometry council is a need of hour for today, and that should have the proportion as we talked about, 1:3 ratio or 1:4 ratio as per the ophthalmologist concern. And the medical colleges which are in a pipeline, which government is going to increase the number of medical colleges across the parts of the state. Maybe every district has one medical college in future. They should have an integrated program for paramedical courses also, because no point having a medical student unless we have a paramedical support, which has to be there, right from the technician to the staffs, which are we call nursing officers. There should be a part of an entire scheme also. So I think that would comprehend the program which you talk about.
Right. So some excellent suggestions there on how to bolster the availability of manpower. Dr. Sabharwal, I'd like to bring you in. We are discussing integrating eye care management, and we need to adopt a stakeholder approach. It cannot just be one sector and not the other. It's going to be the key is going to be bringing in all stakeholders, which includes the not-for-profit sector, the private sector, the practitioner, and also allied healthcare workforce into this for it to become a real success. And we've seen what the not-for-profit sector has been able to do in making eye, the entire gamut of ophthalmology available, accessible, and affordable for every individual. And no better example than Dr. Shroff's Eye Hospital. I'd like to get your insights on some of the successes and some of the learnings through this model of delivery of ophthalmology services.
Thanks, Dr. Karan. I think just taking a clue from all the esteemed panelists, especially following up with Grover and Dr. Tityal, I'd like to divide this into two. One is obviously the actual service delivery, and the second is more of capacity building. So if you look at service delivery and the latest figures that have been published and written, that more than 60% of cataract, which is the major cause of blindness, as pointed out by everyone, including Dr. Praveen Vashish, is being done outside the government sector. And a lot, maybe a high proportion of it is being done by non-profit and some by private practitioners. But to add to that, I'll just point out the thing that Dr. Grover pointed out, in fact, twice, about equity. And I think a lot of these organizations are ensuring equity in whatever way they can by following the cross-subsidy model, giving free surgeries, and actually opening hospitals where the high sort of cost private hospital will not go. So even an organization like Dr. Shroff's Charity Eye Hospital, we have six surgical centers, which will not be in our big cities. So that is one thing. Then coming down to, I think what Dr. Anil also pointed out, the primary care, including Dr. Shroff's Charity Eye Hospital, a lot of non-profit like Dr. LV Prasad Hospital, Arvind Eye Hospital, they are multiple vision centers. So these are the primary eye care centers which are also ensuring equity of access. But at the same time, they are capable of handling the second most common cause, maybe the commonest cause of visual impairment, as pointed out by Dr. Praveen Vashish, of refractive error, because most of it can be handled at that level. So that is another thing I think where the non-profit sector has done well. Coming to capacity building, it was very rightly pointed out by Dr. Tityal, Dr. Grover about the quality of training and the trained personnel. And I think one thing which has not been highlighted is availability of ophthalmologists outside big cities. There was a recent survey which showed almost 70 to 80% of our ophthalmologists are just stationed in 9 big cities of the country. So these hospitals which are outside, and the way we train our ophthalmologists and posting at these hospitals actually has maybe taking care of some part of it. And adding to that again, which was pointed out, we need non-cataract surgeons also, the patient people who can actually operate other sort of fields. So a lot of subspecialty training is going on in right now in private and non-profit sector. Adding on to that, I would again point out the paramedical training. So yes, I totally agree with what Dr. Tityal said. It has to be standardized. There has to be one sort of accreditation sort of policy. But a lot of our organizations like Dr. Shroff Charity Hospital have very sort of standardized training modules for paramedics. And we train up to around 400 to 500 paramedics in a year. And they are required because, as was rightly pointed out, there's no point having an ophthalmologist without a paramedic. You make them ineffective. So I think the non-profit sector has done well in that sense. And I just maybe like to point out one more thing is there are some very good examples of public-private partnerships for some of the diseases like diabetes, ROP, retinoblastomas, where the capacity it's been integration in the government sector. Some of these programs are done well. I mean, just to give you an example, Dr. Shroff Charity Eye Hospital, we are doing a program for ROP, which is covering almost all the Delhi government hospitals right now. So it is just that it is integrated into a program which was anyway there for children eye screening. So I think that has to be developed more. But I think there are some few steps that have been taken which are being effective from the non-profit organization in that aspect also.
Right. I have a follow-up question, Dr. Sabharwal, but I'll come to you after I also get Dr. Pillai in on the role of the private sector and even standalone hospitals, the private practitioner. Everybody has to play their part because we understand the challenge is big and it needs a multimodal stakeholder approach. So how do you think the private sector, the role that they can play and how they can be integrated further into national programs?
Thank you very much, Karan, and thank you very much. So it has been an intense discussion on cataract and a lot of causes of blindness like that. Now, private sector is about 70%. Not all the people who, the government's thought process in terms of increasing the number of medical students in the medical colleges is to create a flooding, which would actually cause people to move away from large cities, which currently is at 70%, to smaller B cities and C towns and then villages. So that is a basic idea of the government. So that brings in that there won't be limited people who can actually get into a government job. There will be limited people who can get into a good NGO, which provides this high quality numbers. So a vast majority of people, and with good training skills which are imparted over the next 10 years. Dr. Tityal and Dr. Grover was talking so much about HR development. So with that, probably the private workforce will be a large force to reckon with. And, currently the private sector is at 70% and the bed share is about 63%. And the cataract surgery rate, even in rural areas, is about 50%, private versus government. It's not about versus, it's about together. So this will make it further forward. How will it make it further forward? Because, including cataract surgery in the Prime Minister's Ayushman Bharat and costing it right, when the number of doctors increase also, they also will have to do, a lot of these surgeries, the number intensive care so that you can bring in these free cataract surgeries for patients. So that is just about cataract surgery, which is a major part, which India is looking at in a huge number, this thing. Even though Dr. Praveen Vasish told us that we are lagging behind a big way, but we are doing huge numbers. Now, look at other problems as well. Now, cataract is a completely reversible cause of blindness, whereas we have time-sensitive, irreversible blindness like diabetic retinopathy. If you pick it up in the first 10 years, you don't go blind. But if you pick up in the next 10 years or like maybe 15 years, 20 years down the line, you come with a proliferative diabetic retinopathy, you lose vision. So picking up that with this huge workforce is also very, very important. So screening for diabetic retinopathy, screening for glaucoma, screening for all those irreversible diseases, and obviously performing a lot of cataract surgery is definitely a thing in the private sector. Over to you, Tom.
Right. And Dr. Pillai, you spoke about the need for adjunct healthcare workforce also to become a part of this. We know if we want to prevent heart disease, we need to get dietitians, nutritionists, everybody involved in the process. Could you throw some light on the role an MBBS doctor has to play, or a diabetologist has to play, or even a nurse or an ASHA worker has to play in this grand mission of eradicating blindness or overcoming the challenges that we currently face?
Yeah, that's an excellent question. I would like to start because there are a lot of policymakers here. Like when we started the first program for blindness in the world, trachoma program, and we were armed with a torchlight. So an MBBS student is basically taught to look at ophthalmology. Currently, cataract can be picked up with a torchlight examination by an optometrist. But what an MBBS doctor should now have is a simple direct ophthalmoscope, which can take care of glaucoma, which can take care of diabetic retinopathy, which can actually be of huge help. Whichever specialty he goes, the optic nerve and the retina are the two areas where he can see the vessels, see the nerve. So direct ophthalmoscopy should be made part of the curriculum in MBBS. Dr. Titial is smiling, I know. but that I think definitely should be there. That will increase the yield of vision-threatening diabetic retinopathy and actually picking up glaucoma in the correct stage so much more than what would be there. And I think definitely we should embrace technology, be it teleophthalmology. Now we were thinking that, technology is very difficult for reaching the villages. The last villager will have a mobile with a network and he will have his Aadhaar card, which means administration as well as the technology can reach the last person in the last village in India. So having a putting it onto the cloud and AI diagnostics is not a long way off. We should be aiming at that in a national program and getting into such a mode so that, from the ophthalmologist-led screening programs, we have to move to the person has to come, okay, my vision, I have to check my vision based on a mobile app. And I have to, come to an ophthalmologist or optometrist or whoever. That should be the change that we should be able to make out by, creating the awareness in it. Because blindness, finally, if there is a major cardiac issue, major neurological issue, die. That's all. But with blindness, you have to live. And for years together, you have to suffer. So we have to somehow create that awareness. Like the funding agencies have to put in a lot more effort into, vision. And because in India currently, the spending in terms of a blind person is not so much because his family takes care. It's not that the state takes care. That's a huge difference between the West and India. So we are not so much inclined because even if there's a blind person, one person will be there because we are a lot of population. We have somebody holding hand and taking him on. But that has to change. And we have to invest hugely into technology which can screen for blindness, pick up early so that people won't go blind. Thank you very much.
That's great. And Dr. Sabharwal, I'd like to ask the same question to you. What is the role of others, if I may call them that, in this mission?
I think Dr. Pillai has touched most of the things, and I feel it has to be integrated at all levels, like he said. It has to start from the community level. I mean, just to highlight an example, he said ophthalmoscope. I would say there's a new sort of innovation which is called ArcLight, very cheaper than ophthalmoscope. And we have piloted it, giving it to your ASHA workers and sometimes Anganwadi workers and sometimes our community health workers who are not trained in eye. And all they have to do is just pick up a red reflex for a child. So simple things can be picked up just looking into the eye using that. So how it can be integrated, why there should not be at least a simple test of eye for every child who comes for immunization. I think it should start from right there. And then having simple vision charts in your diabetic clinics. So at least basic vision is getting tested, or the free applications are there on the Android phone which any non-medical person can be trained in a clinic to at least take vision of any diabetic coming in. So at least the emergency cases can be referred. I know not all will be screened. So it has to be integrated at basically at primary level within the health centers for basic simple vision, and at the community level with all the screenings happening with other fields. I think a lot can be done by the people whom we are calling others for eye diseases. Thank you.
Thank you. And in the interest of time, we're just closing out this discussion. And I say this without any pun intended. We have visionaries talking about, eye care. And we won't get this chance again. So I'd just like to run through the entire panel once again with their Vision 2030. What is it that they foresee by the year 2030, India or the Indian health system having achieved in eradicating blindness or making a meaningful change in that? If you could just spend just about a minute on that, not more. I'd like to start with Dr. Anil Kumar. Dr. Kumar, how do you foresee your Vision 2030 in the next 7 years? Where will we be?
First of all, I would like to say that the panelists gave very, it's a very useful discussion which we had. And, the views shared by different panelists in the program also agree with all those, views. And it's a very good discussion. But I would like to tell you something about the program. Dr. Parveen said that some target, fixed for cataract backlog. And I'm, happy to inform you that for last year, we have achieved the target. So we are moving in that direction that after, 2 years, we will be the cataract backlog free country. So that is a good thing. The second thing, which we were talking about, the primary healthcare level, and the ophthalmic assistant and all those people have availability, their availability for refractive error. Yes, I agree that we have limited availability of para-ophthalmic person at primary health center level. But how the program is doing? If we can create awareness at the level of at the community. And if we can, we can use our resources available at village level in the form of ASHA and other people, and if they can, detect suspect cases of visual impairment and blindness, and they can be referred to the primary health center. I think this demand, if demand is generated, then probably we will be able to recruit more and more para-ophthalmic person. I can understand that we have limited availability, but once demand is generated, then decision making. See, decision making is not only at the national level. Decision making is also at state level and district level. So when decision making takes place at different level, then probably we will be able to produce more para-ophthalmic person. I was having a meeting with the Rehabilitation Council of India, and they are also a partner or a stakeholder to create more for para-ophthalmic person. And I discussed with them that why we cannot work together and to take a decision so that we can have the manpower available as per our requirement. So I got very positive input from them, and we will be working together. So in fact, this is a key thing, that whatever resources we have, and different panelists were talking about that, whatever resources we have in the country, whether it's in private sector or NGO sector or government sector, we need to pull all that resources to achieve what we want to achieve. And we are moving in that direction. In fact, I would like to convey to you that we have some other programs like elderly care program. Now we have certain services we are providing under elderly care program. So we have to use those services also for our blindness control program. And then probably we can achieve what we want to achieve. Similarly, we have to mobilize community. And the third thing is what we are doing. The assistive technology. We have to bring that assistive technology also. That will also lead to sort of changes at the community level, because when services are provided, more and more people will come forward. So the question which you are asking, what how we will be placed in 2030. No, I'm very positive about it because not many changes are happening in our country. Not many changes. We are bringing more information technology. We are doing more program. We are mobilizing, community. So there's so many things are happening, and when we combine all those things, and we are talking about the resource sharing, bringing new technology, I think we will be very near to our goal, what we want to achieve in 2030. This, I'm very, very sure of, which probably we cannot foresee now, because in different sectors, so many other things are happening. Thank you.
Thank you. Thank you, Dr. Kumar. Dr. Grover, Vision 2030?
I'm very positive about the future because I think we've had a glorious tradition in eye care for the last 3-4 decades with pioneers like L.P. Agarwal or G. Venkataswamy or G.N. Rao or Badrinath. So all these people have given us that platform to build upon, and they gave the right direction to the activities. And I think ophthalmology has had a greater tradition of charity or looking after the deprived sections than any other specialty, medical specialty. So I'm very positive about that. Dr. Gopal Pillai touched upon the role of technology, and I would just like to emphasize a couple of things which I think could help in our endeavors. One is the AI is going to be definitely very important as the imaging techniques become simpler, glaucoma, age-related degeneration, all of those irreversible causes of blindness that he was talking about, diabetic retinopathy, all these could be picked up even if we are short of manpower by the use of AI in addition to telemedicine. So that technology part will be very useful. And we are coming up with a lot of technology. As he said, there is an availability of cell phone with the last user, and Ayushman Bharat digital mission has come up, and a lot more things will happen in terms of the use of technology by the present government and all of us. So I think that should help in helping us achieve a lot more. A couple of things that I wanted to point out about the private sector. Private sector has been and will continue to play a very important role, but some of the problems that they are facing should be addressed. I think one of the major problems is, of course, the kind of relationship, patient-doctor relationship, which has suffered, which the whole lot of medical profession needs to work on with the public to build that level of confidence where those things like violence or legal matters, they are sorted out. And the second area is the low reimbursements, which are lower than the actual cost worked out by any costing technology, which would hamper the growth of the private sector, especially because ophthalmology has a lot of standalone hospitals, and they can only provide good technology, which is good at international level. We already know the services are world-class, but they have to be sustained at that level, and is not possible unless the resources are adequate. So those challenges of low reimbursements or arbitrary reimbursements without costing, they will also need to be addressed for the private sector to continue to play an important role. I think these are the areas. One more area about the manpower training that I wanted to specifically emphasize was that, as he said, there is, as Dr. Tyal said, uniformity at the level of training of para-ophthalmic personnel is very important. And the uniformity at the level of ophthalmic residency training is also very critical. And time has come for NMC to think of a uniform exit exam or a single exit exam of the same standard for the entire country. It's been done by the national board, so it definitely can be done by NMC. And that would provide a huge impetus for those medical colleges which do not have enough good enough training or good enough resources for them to build it up in order to have their residents come up to those standards required by uniform exit exam. So this is one area where I would like policy planners to think on, besides other things.
Thank you, Dr. Grover. Professor Tityal, Vision 2030.
I think most of the things are covered. I'll just go into other side of a story, because we know that the blindness will be there. We cannot eradicate the blindness. So we have to look into a preventive aspect of blindness which can be preventable, so that we decrease the pain of an individual and decrease the burden to the society and country. So how do we get into the root of this problem? As Gopal nicely talked about the technology or a digital world, I think if just give an example of a child. If a mother has multiple children, so how do we see would know that which particular children is hungry? It is that children who's crying who will get the things. So today it is the individual. They have to cry. That it is their right to have a health to them, their right to have a vision which is perfect for them. Unless we make the public aware of a blindness, the preventable causes of blindness, and how those can be treated. So actually, it is the public who is going to make the program success. We can try from our side in many forces, but it's difficult to reach each individual in the country. But once we reach the public by this digital media, the root cause can be reached, and our surveys will be simpler, our treatment part will be easier, and implementation of program will also be easier. So if I given an opportunity, I'll be working on that area. I can make every individual awareness of blindness and the causes of blindness and how to prevent that and how to reach to a place where they can be treated. I think that should be the plan. If once we reach each individual, the problem will be solved in next 5 to 10 years.
Wonderful. Thank you for that, Professor Vidyal. Dr. Patanjali, Vision 2030.
I think he's
muted. Patanjali, you are muted. Can you unmute yourself?
Yeah, you're muted.
Yes.
Yes.
Thank you. Excellent points. I would use my 1 minute, Karan. First of all, to compliment you how you rotated the mic and brought up the best from and linked one to another in an excellent way. I compliment you. I myself do a lot of coordination and chairing of sessions. So I noted that. I would say 4 things. One is Dr. Titial brought up, even Dr. Ashok Grover brought up the points on, and of course, Anilji also brought up. Anilji I know for many years when he was in leprosy. One is one is technology. I predict there will be 3D printing of glasses. That's the only way to meet millions of people, that you print. The 3D printers have become much smaller, and we can do that. It will also have the power or interpupillary distance, even the earpiece. So that's going to be one way of meeting these areas. You need not go back to the labs. It would be done there itself. Second, I predict robotic surgery, robotic eye surgery. There will be robotic surgeons, and I see Dr. Ashok Grover, the way he operates, and he and many other. Why I'm talking about Dr. Ashok Grover? Because he operated about my parents. I see how he does it. So there will be a lot of people who would be utilizing robotics as a surgery. So that is going to be a force multiplier. There are going to be many other technologies coming up. You talk about AI. AI, I am not speaking about it because we already know it's there, but quantum data collection for that, as Praveen pointed out, we don't even know how many people are having refractive error. That's a abysmal situation. But yes, because it's too big a task, so data management by technology, by quantums, it is going to come up many more. In fact, I have a session on the coming revolution in ophthalmology, which I did in Bangladesh a month ago, where I brought all the technologies together, and we're happy to share it someday. The next point I predict is capability building would increase. I don't call it capacity building. There's a slight nuance difference between capacity building and capability building. I see with the centers now actually reaching those points and talking about quality, what we are going to focus on is capability building is going to be there by 2030. That will lead us to a large number of people available. As said, not only ophthalmologists, optometrists, but down the line, and as Ganesh, Dr. Pillai pointed out, utilizing even ANMs and ASHA, so many things comes up. The third I predict is there will be an improved governance and the programming, because health being a state largely on a concurrent list, but largely managed by the state. As Dr. TTL and Dr. Ashok talked about, public has to demand and they're becoming demanding. And that's fortuitous for us. In fact, I work on a lot of area of creating the need, demand, supply triad, filling the gap. They don't even know the need. That's why there's no demand. They think, oh, it's going to happen. So we need to understand to create the need, and then the demand will reply, and then the supply will respond. So need rather than demand supply, dyad, like to talk about the need dash demand dash supply triad. And the fourth and the most important one, and I would heartily agree with the previous speakers, and my own prediction is we are going to have the way we have had Bharat Jal Abhiyan and others, there's going to be an India program Sight for All. Because if they're moving down the list, house, roads, water, toilets, and is soon going to come to eyesight. And that is going to depend if how quickly we can clamor, as I said, kaun sa bacche ko doodh milta hai. So we got to clamor as the group of ophthalmologists, but also people, so that Sight for All program comes before, heart surgeries or cancer, which are sexiest, if I can use the word subject. I stop here. And this, I think, would be a real need. And we all need to work towards how to involve the government so that Sight for All program comes. Thank you.
Thank you. Dr. Praveen Vishesh, Vision 2030.
Yeah, thank you. In fact, most of people are positive. I want to give a bit challenging aspect, actually. Till now, we say that in the next 7 years, the chances are that the technology and AI, that will be much better. And probably the diagnosis and identification of disease will be much higher. That means we are giving most of the load on secondary and tertiary level services. That is going to be. In fact, what we have assessed, if we go as the people-centric need, just for refractive error, currently we estimate that the prevalence of refractive error among school-going children is around 10%. And with this number, our estimate that we need 20 million spectacles per year in our country. And at present, the goal of National Program for Control of Blindness is to give 1 million spectacle per year, just 5% of the actual people-centric need. What WHO estimate that by the year 2050, I'm just talking about 2050, the prevalence, there will be 5 billion people with myopia. Number will be much higher. It will not remain as 10%, it will go up to 25 to 30%. You can understand the need is increasing, the diagnosis is easier, more and more people will be requiring services going to second tertiary level. So it's a major challenge. We have to think, we have to plan how to provide such services in the country. Thank you.
Thank you. Thank you, Dr. Praveen. Dr. Sabharwal, Vision 2030.
And I'll come back to optimism after Dr. Praveen Vishesh. I would say that I still feel that technology-driven and integrated eye care would have a basic, high-level impact on avoidable blindness. And when I say integrated, I feel by 6-7 years down the line, it would be getting integrated not only between public and private sector, but also between eye care and the general health. So universal health coverage within universal eye health coverage within universal health coverage. I'd just like to add one more point. Dr. Grover pointed out some of the issues. I would say that private and non-profit sector also have a lot of capacity to build capability and capacity. As Dr. Patanjali pointed out, it's also about capability. And I think there needs to be some more enabling policies and, let's say, by the government to encourage the private sector to train. Because ultimately, the private sector, whenever they're training, or the non-profit sector, ultimately the ophthalmologist is going to have an impact on the national blindness. So I think we need much more favorable policies on that. And if that comes in, I feel even the challenge of human resources can be tackled much better. Thank you.
Thank you, Dr. Sabharwal. Dr. Pillai, last word.
Thank you very much. Earlier I talked about the involvement of technology and all those stuff in diagnostics. Like Praveen Vashish said, this will all create a huge impact on the secondary tertiary care. So what we have to basically do is to create policies and guidelines and what is to be done. It should be a factory sort of thing in which the health worker, the other health workers, the complementary health workers, including optometrists, also will have to play a huge role. And yes, robotics, all those things will come in. But you should understand that ophthalmology, everybody should understand that ophthalmology is something where in every 5 years, newer innovations are being brought in very, very faster. These innovations and these pharmacology, newer monoclonal antibodies that come to us, all that comes with a cost. So the healthcare delivery in ophthalmology, as it gets finer and finer and finer, it becomes costlier and costlier also. So we have to find an optimal path where optimal eye care delivery is done, where people like policymakers like all of you will have a huge role to play. I have my own teachers and examiners here, Tityal sir and Grover sir. So they will all have to play a huge role in bringing standard operating procedures, which if this is the diagnosis, this has to be done. So in a point A or point B or point C, there is consistency. Currently, India is plagued by huge inconsistencies. The best surgeon and the not so best surgeon. So that has to come down. Thank you.
Thank you. But on this panel, we've only had the best voices, the best minds on ophthalmology, on eye care management, and how do we integrate it. I think we should have a transcription of this because it has wisdom, it has vision, it has experience, it has insights, and it's also actionable. So it's very rare that we get a panel which is talking also where we need to go with optimism, with also tempered with some sobering analysis, but also where we need to go and how we need to go. So it's been a fascinating discussion. Dr. Anil Kumar, Dr. A.K. Grover, Professor Tityal, Professor Vishisht, Dr. Patanjali, Dr. Sabharwal, Dr. Pillai, thank you so much for this very insightful and fascinating discussion on how can we integrate eye care management into our health system. And I'm sure with all your efforts and the efforts of the wider healthcare universe, by 2030, we would be a shining beacon of what eye care management can look like for not just LMICs, but also for the so-called first world. With that, we'd like to draw this panel discussion of the IHW Council Blindness Prevention Week to a close. Thank you. Namaste.
Thank you very much.